Hello friends, today we'll discuss about acute pyelonephritis. So this patient presented to us in our hospital last month. This is the 73-year-old male patient, known case of hypertension, diabetes on oral medication with past history of the left ureteric stone removal. First visited to OPD with chief complaint of hematuria, right flank pain and strangury, which subsided spontaneously. USG was done and the other lab test was done. USG revealed mild prominence of the right kidney with high post-void residual volume of 114, and his prostate specific antigen was negative. Considering it was cystitis, antibiotic was prescribed and the urine cytology showed atypical cell and the patient became asymptomatic after taking antibiotic. CT scan was done for this patient, showed no calcific shadows. Right lower lobe was heterogeneously enhanced with thickened pelvic and upper ureteric mucosa. Diagnosis of focal pyelonephritis was considered and the patient was treated with antibiotics. Again, repeat imaging was done after antibiotic course and it did not show any change. MRI was done which showed focal nephronia like picture. Possibility of tuberculosis and fungal infection was considered to rule out TB. Urine culture and the gene expert was sent along with mycobacterium growth indicator TB. All tests were negative. To find out the cause, retrograde pyelography with cystoscopy was advised, but the patient lost the follow. After 4 weeks, the patient presented with chief complaint of weakness, poor fever, poor appetite, generalized tiredness, which increased since last one. Again started with antibiotic. The patient responded to this antibiotic, and this time urine culture showed significant growth of multi-drug resistant CSPL E. coli. So patient was afebrile, discharged to home with ertapenem for 7 days. After stopping antibiotics, patient started spiking fever again. So repeat CT scan done, what suggestive of right bulky kidney with perinephric fat stranding with wall thickened of right pelvic and PCS with necrotizing lymph node in retroperitoneum. So this time patient was started with AKT, but he did not respond to that. So cystoscopy with right retrograde pyelography with DJ stenting was done, and right renal biopsy was done with sent outside, which did not reveal any abnormality. So finally, the PET scan was done, which was suggestive of primary renal malignancy with lung mets. And patient came here for further diagnosis. So the decision of the right nephrectomy was taken, and the specimen sent for the histopathology, which revealed the papillary renal cell carcinoma. In post-operative, this patient was difficult to wean due to persistent acidosis, high TSH value, persistent hyperkalemia. And after correcting this, patient was weaned on the sixth post-op day. This was the histology slide for this patient, which was suggestive of the papillary carcinoma. This was the specimen. So, take-home message from this case: the papillary renal cell carcinoma is common in male and high incidence in the age group of early 60 and 70. In case of recurrent pyelonephritis, which is not responding to treatment, keep high suspicious for renal cell carcinoma. For diagnosis, always consider biopsy and nuclear scan. So we'll discuss about acute pyelonephritis. So urinary tract infection is the broad term that encompasses the spectrum of infectious syndrome that affects the urinary tract, anywhere from the urethra to the kidney. UTI are some of the most common infection, and it is reported that 50 to 60% of the women have at least one UTI in their lifetime. The usual mechanism of infection in the bacteria colonizing urethra or periurethral space, migrating into bladder and causing inflammatory response. The bacteria that typically causes this are formed from GI tract and are collectively called as enterobacterials. Examples include E. coli, Klebsiella pneumoniae, Proteus mirabilis. Another possible way of developing UTI is the bacteria in the bloodstream migrating to kidney, bladder, but this is very rare. Now, common pathogen implicating in the UTI. Uncomplicated UTI, the pathogen responsible are E. coli, Proteus mirabilis, Staphylococcus saprophyticus, Group B streptococci, Enterococci, and complicated bacteria. It's similar to uncomplicated UTI. Antibiotic resistant E. coli, Acinetobacter baumannii, Pseudomonas aeruginosa, Staphylococcus, and Enterococcus. Risk factors for UTI include female sex, recent sexual intercourse, diabetes mellitus, structural functional urological abnormality, urinary catheterization, ureteric stenting, nephrostomy 2, post-kidney transplant status, use of immunosuppressive drugs, and SGLT2 inhibitor. Acute uncomplicated cystitis. Acute uncomplicated cystitis is also known as simple cystitis, and it is a type of the UTI, specifically an infection of the bladder in otherwise immunocompetent host with normal urinary tract anatomy. And classic symptoms are dysuria, urinary frequency, urinary urgency, suprapubic pain in the absence of systemic illness and upper urinary tract involvement. What is complicated UTI? Complicated UTI is the UTI, any kind of UTI which happens in the pregnant female, UTI in the male from any cause, infection due to anatomical abnormalities like obstruction, calculi, hydronephrosis, conovesical fistula, immunosuppressed patient, then in CKD, post-renal transplant, presence of risk, and in those in whom presence of risk factor for the recurrent UTI is there, like renal calculi, indwelling catheter, MDR organism, healthcare associated UTI, CAUTI, and atypical organism. Now, diagnosis of UTI is primarily made by the presence of typical symptoms and can be confirmed by two lab tests like urine analysis and urine culture. Urine analysis of high quality midstream urine sample is often first basic test to aid in diagnosis. Now, these samples can be analyzed for pH, leukocyte esterase, RBC, and nitrate. Now, the normal urine pH is slightly acidotic but ranges from 4.5 to 8. And the more alkaline pH is indicative of infection and urea splitting organism like Klebsiella proteus, Ureaplasma urolyticum. Alkaline pH is indicative of the struvite renal stones. Urine microscopy can identify the presence of white blood cells in the urine, which is termed as pyuria. Having more than or equal to 10 WBC in the urine, it's suggestive but not diagnostic of the UTI. The greatest value for checking pyuria lies in its negative predictive value, which is reported to be more than 85%. Therefore, without pyuria, it is unlikely that patient has UTI. Bacterial counts that are clinically significant are 10 raised to 3 colony count in midstream urine in acute uncomplicated cystitis in female and 10 raised to 4 in acute uncomplicated pyelonephritis in female, 10 raised to 5 in female and 10 raised to 4 in male, and catheter urine sample in female or complicated UTI. Any count from suprapubic puncture is significant. Now, the significance of the leukocyte esterase. Leukocyte esterase, it is the enzyme released from the rice WBC, which acts as surrogate marker for pyuria. So, presence of leukocyte esterase is indicative of the bacterial growth. And it is a screening test with good sensitivity and specificity for detecting more than 10 WBCs. Now, nitrite in the urine are attributable to the ability of some gram-negative bacteria like E. coli to convert nitrate to nitrite. So, positive nitrite on the urine dipstick can therefore be the indicator of bacteria in the urine, specifically gram-negative bacteria. Limitation of nitrite test. One of the limitation of this test that it would not detect the bacteria which with organism that do not have the biochemical ability to create nitrite, such as Enterococci and the Pseudomonas species. Additionally, the false positive nitrite can be seen in patient who uses phenazopyridine which is common over-the-counter urinary analgesic in the United States. The reported sensitivity of both leukocyte esterase and nitrite for detecting bacteriuria was variable, but specificity was found to be more than 90%. Now, midstream voided urine culture was our more direct way to assess the presence of pathogenic bacteria. Bacteria, in some cases, represent contamination. However, in symptomatic patients, this could help confirm the diagnosis of UTI. The classic cutoff for positive urine culture to reflect the presence of bladder bacteria have been more than 10 raised to 5 colony forming units. The following examples are where urine examination is needed. The signs and symptoms of upper tract disease or systemic illness. A typical symptom such as patient who has dysuria, vaginal symptom that can also suggest your vaginismus. Patient at high risk of developing complications such as who are uh, immunocompromised and have urological abnormalities, and patient with the risk of infection with the multi-drug resistant organism with history of or with the history of infection of MDRO or who have had recent course of antibiotic and recent hospitalization. So if there are any lack of improvement and progression of symptom after about 40 to 72 hours. And another important test to consider is the pregnancy in the female of the childbearing age, because pregnancy can affect the threshold to treat the UTI and also the type of antibiotic. Therefore, it is important to obtain pregnancy test if it is challenging from the history. Radiological examination is not indicated in case of lower urinary tract infection. And as per 2017 European Association of Urology guideline, urine culture is recommended in following situation only, like in suspected pyelonephritis, symptoms that do not resolve or recur within 2 to 4 weeks after completion of treatment, female who presents with atypical symptom, pregnant female, and male with the suspected UTI. Now, regarding treatment part, majority of uncomplicated UTI can be treated with oral antibiotic in outpatient setting. Patient with SIRS response and systemic symptom should be hospitalized early and started on intravenous antibiotic. Now, regarding uncomplicated cystitis, as per 2017 US guideline, fosfomycin 3 gram orally, single dose or nitrofurantoin 100 mg twice daily for 5 days are recommended first drug of choice. Alternatively, oral trimethoprim sulfamethoxazole in the dose of 160 to 800 mg twice daily for 3 days is also effective option for uncomplicated UTI with a cure rate of 90% to 100% in region with resistant rate of less than 20%. Next treatment option is fluoroquinolones like ciprofloxacin and the levofloxacin can be considered for treatment with the treatment of uncomplicated pyelonephritis and complicated UTI where local resistance is less than 10%. Fluoroquinolones are generally not preferred as a first choice in view of serious adverse events such as tendinitis, central nervous system side effects, and peripheral neuropathy. So next drug is nitrofurantoin. Nitrofurantoin should be used cautiously in elderly and rather avoided in patients with the creatinine clearance of less than 30 ml per minute due to potential risk of peripheral neuropathy and pulmonary adverse events. Fosfomycin is a newer drug recommended by IDSA for uncomplicated UTI as it has got good activity against the most enterococcus as well as enterobacteriaceae, including ESBL producing isolate. Now, the treatment option for uncomplicated pyelonephritis and uh, uh, uncomplicated pyelonephritis in oral and IV. So in oral form, we can use ciprofloxacin in the dose of 500 to 750 mg BD for 7 to 10 days. We can use levofloxacin for 750 mg OD for 5 days. Trimethoprim sulfamethoxazole for 160 in the dose of 160 to 800 mg BD for 7 to 14 days. Cefpodoxime in the dose of 200 mg BD for 10 days. Ceftibuten 400 mg OD for 10 days. In case of uncomplicated pyelonephritis, we can also go for intravenous drug, which is available in the form of ciprofloxacin 400 mg OD for 10 to 14 days, levofloxacin 750 mg OD for 10 to 14 days, cefotaxime 2 gram TDS for 10 to 14 days, ceftazidime 1 to 2 gram TDS for 10 to 14 days, amoxiclav 1.5 gram TDS for 10 to 14 days, ceftriaxone 1 to 2 gram OD for 10 to 14 days, then cefepime 2 gram BD for 10 to 14 days. So we can also use piperacillin tazobactam, ceftalazone tazobactam, and ceftazidime avibactam. From aminoglycoside group, we can use gentamicin, amikacin. Gentamicin in the dose of 5 mg per kg OD for 10 to 14 days. Amikacin 15 mg per kg OD for 10 to 14 days. From carbapenem group, we can use ertapenem, imipenem, cilastin, meropenem, doripenem. Now, regarding pyelonephritis, the classical symptoms of pyelonephritis are abrupt onset of chills, fever, unilateral bilateral flank pain, with costovertebral tenderness. These upper tract signs are often accompanied by dysuria, urinary frequency, and urgency. So, the acute pyelonephritis may cause gastrointestinal symptoms such as abdominal pain, nausea, vomiting, diarrhea, which confirm the diagnosis. In contrast to cystitis, obtaining urine analysis and urine culture is recommended for all cases of suspected pyelonephritis. Lab findings include pyuria, granular and leukocytic cast, bacteriuria, and positive urine culture. Blood tests may show the leukocytosis with neutrophilic shift, elevated erythrocyte sedimentation rate, elevated C-reactive level, occasionally positive blood culture that proves same organism as cultured from the urine. Now the role of imaging to assist in the diagnosis of acute pyelonephritis when patient failed to respond to appropriate therapy within first 72 hours. To look for the previous occult structural and functional abnormality that may require intervention, to assess those patients at significant risk for more life-threatening complications like diabetes, elderly, and immunocompromised patients, to characterize severity of infection, and to evaluate the extent of organ damage. So in this radiological investigation, the first one is ultrasound. Ultrasound demonstrated abnormality in only 24% of patients. When positive findings of pyelonephritis are found at ultrasound, they can include congenital anomalies, hydronephrosis, renal enlargement, loss of renal sinus fat due to edema, then changes in the echogenicity due to both edema and hemorrhage, loss of corticomedullary differentiation, abscess formation, and areas of hypoperfusion. Then next imaging modality is CT. When imaging is warranted, CT is the modality of choice for evaluating acute bacterial nephritis. It provides comprehensive anatomic and physiologic information that accurately characterize both intra and extra-renal pathological condition. So unenhanced CT is excellent for identifying urinary tract gas, calculi, hemorrhage, renal enlargement, inflammatory mass, and obstruction. So this is so figure 7 is indicative of unenhanced CT scan from clinically documented case of acute bacterial pyelonephritis, which shows asymmetrical enlargement, absence of pyramid of right kidney. Loss of renal pyramid is non-specific marker for edema, which is more typically seen in obstruction-related calculi. Unenhanced and type figure 8 is representative of unenhanced CT that can demonstrate multiple scattered round oval hyperattenuation foci within left kidney, and these findings are indicative of hemorrhagic acute bacterial pyelonephritis. Contrast enhanced CT. After administration of contrast material, Acute bacterial pyelonephritis most commonly manifests as one or more wedge-shaped areas, streaky zone of less enhancement that extend from papilla to the renal. So this is the finding of the acute bacterial nephritis. The photograph of cut surface of kidney showed wedge-shaped lighter region of the renal cortex, which represents the acute bacterial pyelonephritis. And if we see the CT scan of the same, it demonstrates decreased enhancement throughout the same. Now, role of MR imaging, it is especially useful for patients for whom exposure to radiation should be avoided, like pregnant female, or for whom iodinated contrast material is contraindicated. Now, the MR imaging findings are similar to those of CT, including demonstration of renal edema, hemorrhage, renal enlargement, abscess, perinephric fluid collections. Now, the treatment of uncomplicated pyelonephritis. In outpatient setting, patient with the uncomplicated pyelonephritis can be treated empirically with the cephalosporin and fluoroquinolone. More severe disease requiring hospitalization should be treated with intravenous agent. For intravenous option include fluoroquinolone, aminoglycoside, extended spectrum penicillin, extended spectrum cephalosporin, and carbon. Presentations with the sepsis, septic shock mandate early empirical coverage for ESBL producing organisms. A general condition improved transition to the oral antibiotics are needed. Complicated pyelonephritis. As per latest EAU guidelines, the empirical use of certain drugs such as trimethoprim, sulfamethoxazole, amoxicillin or amoxiclav, fluoroquinolones are no longer recommended in complicated UTI. Recommendation supports the use of third generation cephalosporin or second generation cephalosporin with aminoglycoside and extended spectrum penicillin with or without aminoglycoside based on local resistance and susceptibility pattern. Among fluoroquinolones, ciprofloxacin can be considered in case of stable patient where local resistance is less than 10% and there is contraindication to use of cephalosporin. In severely ill patient, the options for parenteral broad-spectrum regimen include beta-lactam-beta-lactamase inhibitor combination, cephalosporin, and carbon. Cefepime with the extended spectrum activity against the gram-negative and gram-positive bacteria is an carbapenem-sparing option. Now, treatment for MDR infection. So these include polystine, tigecycline, cephalosporin, beta-lactamase inhibitors like ceftolozane, tazobactam, ceftazidime, avibactam combination. Target plasma concentration for polystine is at steady state is 2 mg per day. However, the dose modifications are frequently needed as per creatinine clearance due to potential risk of nephrotoxicity, neurotoxicity, and its use is limited due to MDR organism resistant to carbon. Tigecycline is an alternative and is not first choice for UTI, and it has got high volume of distribution due to poor urinary and serum concentration. Ceftolozane is the new cephalosporin that has inherent protection against the hydrolysis from amsibeta-lactamase due to pyrosome side chain. Similarly, avibactam prevents the hydrolysis of ceftazidime by almost all beta-lactamases except metallo-beta-lactamase MD. Recommended duration of therapy is 10 to 14 days except in case complicated by abscess, needing longer course and drainage procedures are as indicated. Asymptomatic bacteriuria is defined as more than 10⁵ colony-forming unit in voided urine specimen without signs and symptoms attributable to the UTI. This is regardless of whether pyuria is present. Asymptomatic bacteriuria is the common benign finding in many populations, including healthy female resident in long-term care facilities, patients with urine tract abnormalities. Studies have shown that antimicrobial treatment for majority of patient population with ASB can increase the risk of antimicrobial resistance and C. diff infection. Therefore, screening and treatment should be avoided for asymptomatic bacteria. So there are two main exceptions for this. So first is pregnant female because treatment decreases the risk of pyelonephritis and negative fetal outcome. Second, population may benefit from the course of antibiotic who will undergo urological procedures associated with significant mucosal bleeding and trauma. Treatment regimen for asymptomatic bacteria in pregnant female include nitrofurantoin, that is 100 mg BD for 5 to 7 days, fosfomycin, that is 3 gram per oral once, amoxicillin clownate, that is 500 mg TDS for 3 to 7 days, trimethoprim sulfamethoxazole, that is 160 800 mg BD for 3 days, cefpodoxime, that is 100 mg BD for 3 to 7 days, cephalexin 500 mg QID for 3 to 7 days. Now regarding nephrostomy tube, obstruction is the common indication for placement of percutaneous uh, nephrostomy tube. It is important to note that urine in the nephrostomy bag is not sterile and therefore not appropriate for conducting microbial testing. If there is clinical suspicion of UTI, testing should be performed on the fresh urine draining directly from the tube. Patient is undergoing invasive procedure, urine can be sampled directly from the renal pelvis. And even when sampling directly from the tube, it is important to only test the urine if there are clinical signs and symptoms of infection, because nephrostomy tube can have AIDS, which doesn't require treatment. Now, regarding candiduria, the task of clinicians when approaching the patient with candiduria is to determine whether the candida infection is contamination, colonization, or infection. For patient with the indwelling catheter and the candida isolate from the urine culture, catheter should be discontinued and repeat urine culture obtained to investigate whether candida is still present. If indwelling catheter is still required, the catheter should be exchanged and new culture is obtained to again assess for a persistence of candida. If candida is again isolated, clinician must then determine whether the patient has continued colonization versus cystitis or upper tract infection. Note that the pyorrhea is expected finding in patients who have indwelling catheter, and this is not helpful in diagnosing colonization versus infection. Treatment of Candida UTI is only indicated in case of persistent candiduria in patients who have symptoms consistent with UTI without alternative etiology. Imaging such as renal ultrasound, CT abdomen pelvis should also be obtained in setting of persistent candiduria to assess for obstruction and need for urology consultation. For candiduria in patients without indwelling catheter, the management approach is simple. First, repeat clean catch urine sample should be obtained to see candida is again isolated. If applicable, patient should be assessed for the presence of concurrent vaginitis. For patients who re-isolate candida in the urine, imaging is indicated to assess for obstruction. However, as with catheterized urine, treatment of candiduria is only indicated when patient has signs and symptoms consistent with the UTI. Exception to this management approach include patients undergoing urological procedure, neutropenic patients for whom asymptomatic candidiasis should be treated. The next is catheter-associated infection. CAUTI has been defined as UTI occurring in person whose urinary tract is currently catheterized or has been catheterized within past 48 hours. CAUTI contribute to the major percentage of nosocomial infection, and the risk is directly proportional to the duration of catheterization. Complications include infection, catheter obstruction, urolithiasis, structural chance of mechanical trauma that are higher in chronic indwelling catheters. Microbiologically, CAUTI is defined as bacterial growth of more than 10 raised to 3 colony forming unit per ml of one or more species in single catheter urine sample or midstream urine specimen from patient whose catheter was removed in past 48 hours. And the most common infecting pathogen continue to be E. coli along with other Enterobacteriaceae. Pseudomonas, Enterococcus, Coagulus negative Staphylococci, and Candida. Proteus mirabilis have been isolated frequently from chronic indwelling catheter and is difficult to treat and persist for longer period of time. Urine culture should be obtained from freshly placed catheter in patient with suspected gouty before initiation of antibiotic because of wide spectrum of causative pathogens and to minimize likelihood of developing resistance. Now the treatment and prevention. The recommended duration of antibiotic course is 7 days, which may be extended to the 14 days in patient with delayed response, irrespective of the patient being catheterized or not. Catheter-associated asymptomatic bacteria should only be treated in some case of traumatic intervention. Now the preventive measures are avoid and limit the use of catheter to minimum as minimum as possible. Alternative modes such as intermittent catheterization or condom catheter in male may be practiced. Minimum use of perioperatively and prompt removal post-procedure if feasible. Regular follow-up of institutional policies and catheter discontinuation strategy to ascertain that catheter are timely removed when no longer indicated. The use of smallest size catheter possible to minimize trauma. Currently, guidelines do not advocate routine use of antimicrobial coated catheter. Practice appropriate hand hygiene and aseptic precaution before and during insertion. Application of closed drainage system and collection of sample done with the complete asepsis. Avoid irrigation and flushing of catheter. Regarding recurrent UTI, it takes many different. They may be precipitated by sexual intercourse, most frequently in premenopausal female, but also in postmenopausal female. Postmenopausal women are especially prone to recurrent UTI due to increased incidence of atrophic vaginitis and changes in vaginal microbiome precipitated by the lack of estranization of the tissues in the vaginal lower urinary tract. Recurrent UTI in male are associated with underlying structural issues leading to urinary retention and presence of indwelling catheter. And there are association with the recurrent UTIs related to sexual activity related to the spermicidal contraceptive. For postmenopausal female, especially those in whom there may be associated incontinence, pelvic examination to exclude pelvic floor dysfunction and prolapse is advised. Vaginal estrogen can be applied. Role of prophylactic antibiotic. Postcoital antibiotic can be effective in decreasing the incidence of UTI, and is most well-studied agent is trimethoprim sulfomethoxazole. Continuous prophylaxis has been shown to be effective in clinical trial, but the efficacy is lost once prophylaxis is stopped. Further prophylaxis is not usually 100% effective. Thank you.